So hello everyone, my name's Jamie. I'm one of the teaching fellows in most department, like James said. I'm going to talk to you today about red flags. This is, do you know which play that's from? Which musical that's from?
Yes.
What is it?
Oh god, really massive famous. Is it Les Mis?
It is Les Mis, yes. It's a proof to James that I have a bit of culture, because he considers me very much beneath him. So this is a proof that I do know a little bit of culture. If any of you are on Twitter, I'm on Twitter. I like tweeting. I'm not called McDreamy because I have aspirations of grandeur. It's because I work in Dream, hence the purple. So that's a kind of a pun. We're all familiar with the concept of red flags, I hope, although I think they mean different things sometimes to different people. I'm a massive F1 fan. The red flag in F1 means stop what you're doing, there's problems, you need to stop. In medicine, certainly don't stop. You're going down a certain way, there's a clear path available, open to you now. The last thing you should do in medicine is to stop. Just by everyone's background, where are we all working here? Where do you work?
I work at a substance misuse unit at Highbury Hospital in Fulham.
Cool.
Yourself, the same, my country.
Cool. Cool. Matron in vulva. Better behave in front of me.
Yes, I'm a matron as well.
Oh gosh. Okay. Yes.
In housing group.
Okay. And you work in A&E, don't you?
Yeah, I'm doing that.
I've known you for a few years. That's right. Okay. So different backgrounds. Everyone has a different idea of red flags, and hopefully, going through this course, you'll find every system of the body has its own red flags that are important, that need to be picked up, and that's why we always have screening questions, the key questions that you always ask. Okay. We're also going to talk a bit today about bias, and sort of introducing that as a concept. I'm going to ask you what colour this dress is. Yes, finally! Yes!
What? I don't understand how anyone can see white and gold.
Usually I'm the only one who sees white and gold.
Are you joking?
Usually I'm the only one, and I've got a
You
room.
see white and gold?
Yeah.
I see white and gold as well.
Thank you so much. So, Helen, your top is blue. The seats are blue. That is white, as far as I'm concerned. That's white. It's the same colour as that. And it's got yeah, bizarre, isn't it?
Yeah, you see probably people in that like a person.
So this was viral a few years ago, wasn't it? It was somebody messaged their friend saying, "What do you think of my new white and gold dress?" or something. I know they were like, "What do you think of my blue and black dress?" And they replied, "What you on about is white and gold," and it became this big thing. I know in real life it is blue and black. I know, my eyes are wrong. Okay. I can't help that though. It's something to do with my eyes, your eyes. We see this as white and gold. There is a scientific reason behind it. No. I don't know. But this is this idea, isn't it? Because you all go back and you think, why on earth did such and such, why did this doctor, why did this nurse think this patient had X, when clearly, with the benefit of hindsight, they had Y? We all know that. We've all been in M&Ms, we've all been in those meetings, looking back sometimes when things may not have gone quite as well as they should have done, going, well, clearly this was, an aneurysm rupture. Why did the doctor think it was a pulled muscle or something? And I'm now stood in front of you, trying to teach you, and half of you thinking, what an absolute idiot, he can't even tell what colour a dress is. Okay. Well, I can't help that. We all carry our own bias, we all carry around our own feelings that can sometimes get in the way. So, red flags. What soft drink is this? Absolutely vile drink. But what's the worst that could happen? Red flags are there to keep us on our toes, I think, and just to remind us not to get carried away and to take a bit of time to ask those key screening questions about a patient coming in with a presenting complaint. Because I think the media in particular can be very big on stories like this, can't they? They focus on that 1 in a million case. They don't actually mention the 99.99999% of patients we do amazing work on, and there's always this one that slips through the net, and it's like, oh my god, and we beat ourselves up and things. But red flags are there to protect us as well, to make us think about these things. You know, a student comes in thinking she has precious flu, you know that she'd have had some triaging done, somebody would have picked up the observations weren't very good, the doctors would have done blood tests and picked it up. It's there to remind us, because we all know patients coming going, oh, I've just pulled a muscle in my chest, it's not a heart attack, doctor, it's not a heart attack, it's just a bit of indigestion. You've got to use our red flags and use our clinical nows in these cases. Where's Wally? Can you find him? Oh, damn, there's always one in there. Do you all see him? Yeah. So, in our mind's eye, we know what a patient with a pulmonary embolism looks like, or somebody with a AAA looks like, somebody having a heart attack looks like. We know what that looks like. We know what Wally looks like. There's our streaming room. Go find the heart attack. And you've all spotted him, nice and easy. Where's the bad guy? Can you see the bad guy? The one in, is it Waldo, the one in yellow and black? Where? To the left? Yeah. Can you see the girl? I forget her name. Is it Wilma? She looks like Wally, but she's a girl.
Is that her? The hat with the hat, yeah.
Where?
To the right, stop.
Ooh, there she is. Yeah, can you see the wizard? It's a guy with a blue hat, white robe, and he's carrying a stick. A red robe, and he's carrying a stick.
Oh, there. Above the green and white umbrella. Yeah.
Cool. And there's some amazing examples of sunburn going on, which no doubt A&E will be full of this coming weekend. Yeah. So, as I said, we know in our mind's eye what Wally looks like, and if I go back and then put the screen back on, your eyes are immediately going to go to that area. And this happens with our patients, especially if something rare comes along. So I remember a patient, I can still see her completely in my mind, who I thought was just having a heart attack, was sort of treating her as a heart attack. Turned out that she'd actually dissected her aorta. Okay, so poorly. The very next week, the very first patient I saw with chest pain, I automatically thought I went to Wally straight away. She's an aortic dissection, and worked her up as an aortic dissection. Scanned her, and she was actually PE. I think it's weird. But, you know, I jumped straight to Wally, I jumped straight to that moment. I didn't think about maybe the other potential characters in play there. So that's an important thing to think about. Are you guys in the community, seeing patients, sometimes feeling it's a bit of a crossroads? Where do we turn to with my patient who's coming telling me that they've lost weight unexplained for the last month or so, or they're coughing up blood or something like that? And we have different places to go, you know, different pathways. You know, what's this pathway going down here to, all the way up there? That one's a bit more clearer. This one up here, I don't actually know what that's supposed to be. I've got to think, where's the best place that we take our patient forward? And you guys all have. Do you have performers for that? If you've got a patient in the community, where you need to send them to? Is it all clear? Is it helpful? Ish. Why only ish?
A lot of it with our clients can depend on you know, if they've previously not engaged on services,
Yeah.
not always keen to then engage. Recently, I think it's been a lot of, like anything, a lot of teams have been cut down to bare minimal staff, and then we're requesting somebody to come in and see, you know what I mean? So I think it can vary, but I think the pathways are probably there ultimately. It's just,
we get a lot
they
of
always work.
afternoon, we don't really pay more.
But it would be like that for me in A&E. If I'm not entirely sure, I've got this undifferentiated patient in front of me, I'm not entirely sure. So do I send them, do I just admit medics, because that's nice and easy, because there's nobody in my way? Do I admit surgeons, where there's a big nasty consultant stood in my way telling me, why? Or do I go back to see your GP? Not quite sure, maybe. Hopefully it's as easy as that way up there, maybe. I don't know. And this is the kind of the thought processes, again, that go through our minds. I like this diagram. I think a lot of medicine, a lot of nursing, I think a lot of education is just these random dots that are there that, cardiac chest pain is always central and crushing, always sweating, always goes to the left arm, always gives you pins and needles. You're always aged 40 plus, a smoker, fat, blah, blah, blah. And then you meet the thin chap who runs every day, who comes in with burning chest pain that's just like indigestion, that just no family history whatsoever, and turns out, Capone in 10,000 had a heart attack. And that comes with the experience about joining those dots. And a lot of my students, both nursing and medical, find that when they come to A&E, they kind of like, oh my God, why would, this is not at all like it is in the book, and that needs to be appreciated as well. Cool. What animal made this footprint? It's a hoofprint. What animal made it? Horse. Or a cow? Yeah? Deer? So this is your patient coming in, young asthmatic lady comes in with shortness of breath. What's the diagnosis? All you've got is a limited amount of information, what you're hedging your bets on. Difficult, isn't it? But like James said, you can sometimes be led on, so come and see this asthmatic who's short of breath. Come on, Jamie, come and see this asthmatic who's short of breath. Come and prescribe some nebs for this patient who's asthmatic and short of breath. Automatically I'm being led along a path, aren't I? Our words need to be very careful with our words sometimes. What animal is it?
A donkey.
Donkey?
Or a zebra.
Or a zebra. Why maybe zebra?
Landscape.
Yeah, so there's a bit more information, isn't this? This is our lady who's an asthmatic, who's telling me now, oh yeah, how have you been? Oh, fine, I've had this lovely holiday over in Australia. I only got back yesterday. It was lovely, lovely holiday, doctor. Had this lovely time. I've been really well, no chest problems whatsoever. Now I'm just really short of breath after my long 12-hour flight. Okay. And your health's okay normally? Yeah, asthma's really good actually. I'm not normally short of breath. Okay. Are you on any other medication? Oh yeah, I take the pill. Yeah, I'm on the pill. Okay. Any family history things? Oh, well, my mum has to be on that blood thinning thing because she gets blood clots a lot. So a bit more information. Finally, it's a zebra. Yes, Helen, well done. Yes. Okay. So it's difficult, isn't it? You've all heard that expression. If you hear who's horse or versus zebra, think horse or not zebra. It's important though to always keep that open mind and always remember those patients that get labelled as something, functional abdo pain coming in, but they're still unwell, and people get labelled wrongly sometimes, and you need to be very aware of that. So it's time to do a bit of an exercise. So you guys here, I'd like your team chest pain. You guys are team headache, and you are team tummy pain. We haven't got enough for a team back pain. Okay. What I want you to do is imagine that you've got a patient, whenever coming up to you going, I've got this condition. What are those key questions, those key red flags that you're going to be looking out for and going to make sure that you're asking, either in the way it's presenting or in the background of that patient who's presenting either with chest pain, headache, or tummy pain. So, team chest pain, would you like to present your work?
Oh.
Please.
Well, I'm afraid we've not got any pictures.
It's all right. As I said, it's neater handwriting than mine, as Helen will testify. It's a bit like hieroglyphics.
We just listed a couple of things that we thought. So location of the chest pain, radiation, is it radiating anywhere else?
Yeah.
The type of pain and onset as well.
Yeah.
All these are not in any order of how we'd ask either.
It's quite all right.
Shortness of breath.
Yeah.
Then look at things like the age, occupation history, how long they've had it, duration, any palpitations, numbness, tingling or pins and needles, any dizziness or nausea, cyanosis, the activity that was leading up to the presentation, and then lifestyle, maybe the smoke.
So obviously that won't be on the order with us, but it's just...
But no, it's there, isn't it? It's good, it's going through your mind. Brilliant. So when you say like type of pain, is there a type of pain in particular you're thinking then?
If it was a stab,
yeah, dull or sharp.
Sharp.
Is it ongoing?
Yeah. Sudden things tend to be a bit dodgier.
Yeah.
5 years of med school taught me that sudden tends to be
And how
dodgy.
they're presenting in their body, with a walking, like they're walking, able to walk,
Yeah.
that sort of thing. But,
All goes into it, isn't it?
Yeah.
The mobile phone positive patient that tells you it's 10 out of 10 pain. Sorry, 1 sec.
Yeah.
Yeah, 10 out of 10.
Yeah, 10 out of 10. Morphine now. Yeah. We've all been there. Yeah, we know. Yeah, brilliant. So it's interesting. It's interesting, isn't it? So I think you've all got to get it all together, isn't it, in order to paint the whole picture. You can't really, with chest pain, put one thing down to, oh, I've got this, therefore it must be that. It's really, it's a whole smorgasbord of things. That's a good word. So, like I mentioned earlier, people say that it's all got to be crushing central chest pain that radiates to the left arm, and that's why I was taught at med school. But increasingly, evidence points away from that. Actually, the most sensitive thing about whether a chest pain is cardiac is the associated symptoms. It's actually doubly sensitive. That it made you nauseated, it made you sweating, is actually more sensitive than the fact that it was crushing in nature. So actually, the type of pain doesn't really matter. Interestingly, while people report radiating to the left arm a lot more than right is more sensitive as well. It's very interesting. So you find these things that we hold dear to ourselves in medicine, when you're actually doing the evidence, it's actually like rubbish, and you go completely against what you've been taught in medicine. Brilliant. Shortness of breath, you think of PE there, weren't you? Exactly.
Yeah.
So it's
and the lifestyle,
and there's family history in that as well, isn't there? Yeah. Brilliant. Very good.
We'll have that one.
Yeah. Team headache.
Right, so reflexes and trauma for headache that cause headache, sudden onset, loss of consciousness, vomiting, vision disturbance, weight loss, any medication associated with falls and flags, alternate exams for weakness, confusion, facial weakness, history of seizures, the constant low pain relief will take it away. Hypersensitive to light, whether that's like terminology.
So photophobia. You might say photophobia there. Yeah, that's fine. It still means the same thing.
Neck ache, age, previous family history, so like thorax.
Very aneurysms that run in the family, don't they? Brilliant. Yeah. So you're sort of thinking, so trauma, I mean, that's automatically, isn't it? I think we'll think of anything, traumatic chest pain, traumatic outbreak pain, it's always going to be a red flag. The sudden onset, again, dodgy, we talked about that. Lots of consciousness, reduced GCS, yeah. So with these things, you're thinking, is there something that's raising the pressure inside the head? Is it blood? Is it a tumour? Is it something else that's going? So, loss of consciousness, vomiting, that's a sign of raising pressure, vision symptoms again. So weight loss there, you think maybe tumour, so there's something going on, spread, brilliant, yeah. Confusion, I think it's all the really good things there. Photophobia, so what's that a sign of? Yeah, so that goes with your neck pain, isn't it? That's when you've got meningeal irritation. Is it there's an infection or is it blood? So you can get that as well with the subarachs as well. And we really, that neck stiff is going to be really just like staring at the ceiling rather than moving the head at all. It's brilliant, yeah. It can be very, very difficult because does anybody here a migraine sufferer? Has anyone here ever had a migraine? Know anybody who's ever had a migraine? Seen anybody having a migraine? Yeah. They look ill, don't they? Yeah. I mean, I remember seeing a young chap who came in and you'd have sworn he was having a stroke. He was properly fast positive. Luckily for me, as the clinician, the week previously he'd come in with exactly the same, had a CT which was normal, been seen by the neurologists and diagnosed with a hemiplegic migraine that presents with a headache and gives you these stroke symptoms. So it's exactly the same. So we treated him as a migraine and he got a lot better, but it's really startling, covering their eyes, really like snapping because they're in so much pain. It's really nasty. It's really difficult. Yeah, it just came back. It's just like, but you'd have sworn if you just pointed at him in the street, what's that boy got? Even though he was a young bloke, but what's he got? You said, it's a stroke, clearly. And it was just this really nasty headache, yeah. So I always think whenever they come in, anything like this ever before. So if somebody comes in going, yes, I always have migraines, this is exactly the same as my migraine, I saw squiggly lines, I knew it, I've had some chocolate, it always sets my migraine off, that's reassuring. if it's me, who's never had a migraine in my life, comes in with a new onset, really nasty headache, that's more concerning. As is the new headache that comes on later on in life. So a lot of things that comes on, young people start with asthma, young people start with epilepsy. It's a young thing that you go on for the rest of your life. When these things maybe start later on in life, that's that more dodgy. The shortness of breath that starts later in life, the headache that starts later in life, that's time to think more dodgy. Excellent, really, really good. And anticoagulation, I always really work. Yeah, I think that's a spot-on thing as well to think about. Finally, team tummy pain.
So red flags we got were age, sort of PR bleeding, hematemesis, watered down habits, back pain, their past medical history, how sudden the onset of pain is, whether they've lost weight, previous abdo surgery, if they're pregnant, abnormal odds, and also if they've had trauma.
Is that a train crashing into a car? That well-known trauma, the car versus train that we always see. Yeah, excellent.
Because it's normal to have man versus cow, but we've had that one.
We have had, yeah. One of our senior nurses was caught on telly going, a cow? On the phone.
Man versus cow?
Yeah. So you mentioned past medical history. Anything in particular there?
So if they're known to have like a AAA, although that wouldn't. Yeah. Mm-hmm. Yeah. Or I don't know. Or if they've got colitis, or
Yeah, absolutely. Yeah, spot on. Yeah. Your previous surgery, what are you thinking about there?
So there might have been, I don't know, some contents left and they've got like sepsis or surgery.
Spot on, yeah. So adhesion's a big cause of bowel obstruction. So everyone happy with what an adhesion is? It's the scar tissue that's left behind. Yeah, brilliant. Yeah. And you're completely right about, it's the classic of intra-abdominal sepsis following surgery, about 10 days down the line, so they'll have gone home from there, and I've seen patients like that have their day case surgery, come back 10 days later with a really painful tummy because the surgeon made a little nick that got missed on the day, and it's just been going on. So that's all good. Back pain, so it's AAA there, aren't you, again? So AAA, massive. Age as well is a big thing, so I have an incredibly low threshold for scanning older people coming in with tummy pain, because they're on lots of medication, beta blockers, things like that. They're not going to have a tachycardia. They don't have the great muscle definition that I have, so they're not going to guard their tummy particularly well. They tend to be very stoical as well, and they don't want to make a fuss. And then you scan them and they've got the most horrible pathology. They've perforated or something like that going on. And the Royal College has sent out a warning thing, poster saying that to have a very low threshold for these patients, because their mortality rate could be 6-8 times higher than somebody like us coming in with abdominal pain because of the associated risks. Spot on. And pregnancy, of course, I think. Pregnant women in general scare me. So, especially when they come in with tummy pain. So yeah, absolutely. Excellent. Right then, so that's some very good red flags there. It's time for one final activity. This one is going to be based on bias. Okay. So what I'm going to do is I'm going to pass out some definitions for you. These are all examples of clinical bias. If you want to be in your groups that you were in, the red flags. Those are some definitions, and these are some clinical examples. So, a 28-year-old girl sees you about a concerning mole on her arm, and you say to her, you rule out cancer because you're too young to get cancer. These aren't real examples. No. These are ones I've invented. They're not examples of good practice.
And we're meant to say what type of bias.
So yeah, so just have a look at that. Have a look at those definitions that are there. They are matched up. So some of them could be potentially more than one. So you think overconfidence. Framing. So 28-year-old focusing on the age thing. Playing the odds. So it's actually an example of playing the odds. I mean, like I said, a number of the different things could be, you could say, so obviously whoever says this is overconfident, and they are framing it in a way because they're just looking at 28-year-olds are all healthy, aren't they? 28-year-olds don't get ill. But this is an example of playing the odds, just going, look,
Chances are.
hearing horses, not zebra, off you go on your way. Potentially giving this patient the credit that they deserve. Dodgy. 51-year-old man known to suffer from anxiety and depression presents with shortness of breath and chest tightness, and you believe a panic attack is the most likely thing. Psych out error.
Also maybe fundamental attribution error. Because you're judging them. Saying you're behaving this way because of your anxiety.
So this is,
Undervaluing it.
I think again this is an example of psych out error. Again, I think there's some fundamental attribution error here as well, but this is primarily psych out error. I think this is a massive problem that we do. I think not just in A&E, but I think overall within healthcare. Somebody who's labelled as schizophrenia, depression, comes in with a thing, and it's put down to the mental illness. 5 years of med school, never once did I hear the fact that schizophrenia is a protective thing against MIs or whatever like that. That these patients can still have organic, medical problems as well as other things. So, we have to be incredibly careful. And again, I say it's this example of the language that we're using and giving them the credit they deserve. 66-year-old male diagnosed by the GP with a UTI last week presents with sudden severe back pain. You advise it is most likely his urine infection. Diagnostic momentum. So satisfying?
Yes, you know he's got a UTI, so you're thinking about it.
Do you know he has a UTI?
No, but that's what the GP thinks. And he's not willing to look
Did that
outside.
GP do a urine dip?
Probably not.
Do we know? Probably may have done, but I'm being deliberately vague. So what did you guys think? So satisfying? You guys thought diagnostic momentum? What do you guys over here think? Yeah, one of the top two. So I primarily thought diagnostic momentum, but there is a degree of search satisfying there, isn't there? So, I mean, James will back me up on this thing. When we go to, so every month in our department we have an M&M meeting, and it's where we go over the cases that not necessarily went as well as they should. And I think the biggest problem, I've never audited it, but I think the most common error that goes through is a label that was given, a diagnosis that was given far too long, far too much respect, and wasn't challenged enough. That patient labelled as having a UTI comes in with really nasty back pain, looks shocking, looks sweaty, but you keep going on with that UTI diagnosis when actually it could have been something a lot more serious. And I think that's something that we need to be aware of. We don't know how the GP diagnosed the UTI. Did they dip the urine? Did they, ask those questions, or did they just go, probably a UTI? We don't know. And you guys work with doctors, work with ACPs. If I say it's probably this, but the evidence is changing, we need, as colleagues, to be willing to challenge and say, do you want to have another think again? That asthmatic who's just come back from that long haul flight, who's on the pill, and her ankle's a bit sore. Are you sure, or you think it's asthma? You exclude a heart attack as a possible diagnosis because you once saw another patient having a heart attack and they presented differently. Bit of playing the odds, maybe?
Could be zebra retreat.
So you're thinking MI comes into your mind, but you go away thinking maybe I don't want to go down that road.
Yeah.
So there's primarily, I think this is, like I said, there's a lot of different things, but I think it's primarily is overconfidence. Okay. But you've seen one, therefore that makes you feel, I've done that, I've conquered heart attacks now. I'm okay with heart attacks because you've seen that one. When I graduated first in F1, I was far too overconfident for my own good. And I came into the world of medicine believing I was God's gift to the world of medicine. And that I was just going to swan onto the ward and just go, you are healed, walk again, like that. I had a very rude awakening, as you can imagine. We always have to be careful. And I think the big thing is, I guess, patients, as I said, for different reasons present differently. Some patients just don't like using the word pain, for example. They'll come in going, oh, I've just got some indigestion, doc. Well, indigestion is chest pain, isn't it? But you say, oh, so how long have you had this pain? It's not a pain, it's indigestion. Or I've got this ache, so tell me about the pain. No, it's an ache, it's not a... Fine, okay. Tell me about this ache or this twinge. It's amazing. Some people just, no, it's not a pain. Oh, okay. But then when pain's taken away from it for some reason, and they use these other languages, maybe because their wife's present, because it tends to be a bloke, or something, for whatever reason, you start going away from it. So, it's this indigestion. Oh, so tell me about this indigestion. And you find yourself, hang on, I'm going along down this road, let's back along a little bit. A patient with a head injury tells you they remember the whole thing. You decide not to question further. Yes, it is, but, there is a bias at play. Well, there's several biases, you could say, but yeah. Zebra retreat was one thing, yeah. Search satisfying. What do you guys think? Search satisfying, yeah. So again, this goes into your, I don't want to make a fuss, I just want to go home. Tends, an older person maybe, don't put me in a home, I want to go back home, I value my independence, I've just had a trip, I swear it was just a trip. And you look at them, and they're covered in bruises on their face, and you look at their hands and they're absolutely fine. If I pushed one of you over, you put your hands out, wouldn't you? And you say to them, well, why didn't you put your hands out? I remember the whole thing, I definitely didn't black out, but you've not put your hands out, you face planted the floor. But like James said, it's very easy. I tripped, fine, mechanical fall, off you go. Back, scan their head, that's fine, off you go. Not going down the whole, do you remember the whole thing? Did you feel short of breath? Did you feel dizzy? Was there any back pain, tummy pain, headache, anything before you fell? Was it a fall? Well, yes, exactly. Well, sadly, yes. Was it actually a fall, or was there something else? Exactly. Especially hot weather, like we're having at the moment. Good old vasovagal. Good old vasovagal collapse. Oh yeah, tick that box. You've had a vasovagal. Well, was it really? No. Unless they felt they were stood up and hot and sweaty and felt like they were going to pass out. No. A 45-year-old morbidly obese woman complains of chest pains on walking. You believe that she wouldn't have these problems if she got some exercise. So these are not my values. I don't want you to think, oh God, what a... No. Fundamental, yeah. It's very easy to be judgmental, isn't it? Our amazing ivory NHS tower where we know everything and our patients are mortals who are not allowed to, make any mistakes. You could say yes in one way. If she's having ischemic heart disease, if she had lost some weight, she'd reduce her ischemic risk, but you're not giving her that credit, are you, that time of day that she actually needs. And again, I think it's something that we could be very bad at, that alcoholic, that drug addict, we do put these words on. I think this is something that I think we have to be so careful about, and it's not necessarily things like drug addicts or alcohol, but if I know that the next patient I'm going to be seeing, and I'm reading through their list, has sworn at my colleagues, has been rude and abusive, is kicking off and is not very nice, I'm very aware when I walk in of this, to be very careful. Are they, just because they're not very nice, is there a medical reason they're not being very nice? Is there's something else going on, then just to be careful to make sure if there's anything that's telling me get away from this James, kick him out, get rid of him, it's just this, that, the other. So I just think, hold on, actually get back in there, because you need to be careful. You think a patient might have a pulmonary embolism, but you document that you think it's an infection. That's easier to manage. You don't need to ring anyone. Just give some antibiotics, off you go. It's a bit of playing the odds. Infection is more common than peeing. The overconfidence, yeah. Or maybe something in some ways not so much confidence if you think, actually, I don't want to... Yeah, so maybe exactly. So you think you're hearing the who's, but you're going with horse over the zebra. What about you guys? What do you think?
I'm not so sure it's much of a bias. It's like just really bad practice.
Well, yes, it is a form of bad practice. Yeah. Yeah, but I think. It's this example of the zebra retreat that you think that there is that thing, and actually evidence has shown that if you think it's a PE, that's incredibly sensitive for it being a PE. I read a paper where they'd tested Gestalt, which is your clinical thought process, versus doing the D-dimer blood test. I found that it was actually incredibly sensitive, that if you think it's a PE, that gut feeling, that should be listened to. But yeah, so that's an idea of zebra retreat, that you think, actually move away, and treat something that's maybe a bit simpler, a bit easier. Maybe is nicer to tell the patient, oh, I've smoked for 50 years, I'm losing weight, I'm coughing up blood, here's some antibiotics, go back home, because you don't want to raise the issue of, could it be cancer or something like that. Finally, drug A saves 30% of patients. Drug B doesn't save 70% of patients. You choose to use drug A. Hopefully you've realised that, but you use drug A. You have to be aware of this. Drug companies like to use information carefully. So what's this an example of?
Framing?
Spot on. Framing, yeah. So carefully selected information that you choosing to use only certain bits of information or information in a certain way, because hopefully you've realised this is exactly the same data. So both save 30% of people, both don't save both save 30, don't save 70. But the way it's framed moves down a certain way. Okay. And that could be what patients are telling us as well, that we choose only certain bits of information to listen to as opposed to other bits of information. We have a podcast from here in Dream. It's called Take Orally, because you take it orally to the videos. Please don't. If you, we're on iTunes and we're on SoundCloud. We're soon going to be on YouTube as well. If you search for us, we're nice and free. Can be downloaded, can be streamed off SoundCloud, and it just goes through a lot of the conditions that you're going to be learning about on your course, like acute coronary syndrome, like COPD and asthma. They're about half an hour long. Free. Just make sure you spell orally properly, otherwise you will find podcasts that have nothing to do with medicine. They might be teaching you some other things that I cannot be held responsible for. Yeah, like I said, iTunes, SoundCloud, soon to be on YouTube as well. So we can't cover everything. I hope it's just an introduction. These are things that will be hopefully going through your head as James goes through, and myself go through some of the systems. We'll do a lot of focus on the key sort of red flags and bits like that, because they are the most important things. Do you have any questions about anything we talked about? Thank you. It's been a lovely audience. Thank you very much.
Thank you.